All right, we'll go ahead and start. So, good afternoon, everyone. Thank you all for joining today's webinar, Cultural Competency Unlocked with a Focus on Pregnant Women. Today's presentation is hosted by Vital and the Alabama Department of Mental Health. Please visit vitalalabama.com for resources, both for professionals and individuals in the community. Also, you can find more information about the free Connect Alabama Treatment Finder app. Virtual attendees will be muted and your video will remain off. You will use the Q&A box to ask the presenter questions during the presentation. At the end of the presentation, the Q&A box questions will be asked to the presenter. If you experience any technical issues during the session, please feel free to message in the chat box or contact awtornay@ua.edu, which is also in the box with the number as well. We're excited to have Marianella Rodriguez-Ronaldo with us today. Marianella is a mother, a certified lactation educator, and a clinical psychologist with a specialization in prenatal mental health. With over 15 years of dedicated experience in the field, she's become a leading expert. Marianella serves as a volunteer coordinator for Postpartum Support International in Puerto Rico and is also an international trainer for the organization. In her role as a psychologist consultant for the Puerto Rico Department of Health Mother, Child, and Adolescent section, she contributes to both the Fetal and Infant Mortality Review Board and Maternal Mortality Review Committee. Additionally, she provides supportive psychotherapy to individuals living with HIV at the Center for Maternal Infant Studies at the University of Puerto Rico. In 2020, Marianella co-founded Puerto Rico's first Center for Prenatal Mental Health and a pioneering initiative focused on research, awareness, and services for the vital population. Without further delay, once again, we welcome Marianella Rodriguez-Ronaldo as she shares insights on the importance of cultural competency for pregnant women. Dr. Rodriguez, feel free to take it away.
Thank you, Leah, and thank you for Vital Alabama for inviting me, and thank you everyone for joining me for this next hour, and hopefully we can share some experiences, answer some questions, and talk a little bit about cultural competency in the perinatal period and the perinatal care. Let's get started with our objectives. This is what we plan to cover in this, again, small amount of time that we have, but we'll make the most of it. I want to define cultural competency and what that looks like, and also the term cultural humility, which are similar concepts. And hopefully throughout the presentation, we'll be talking about how those impact perinatal care delivery. And delivery of care. I want to talk about some of the shifts that are needed to reduce maternal health disparities, and share with you some strategies to integrate culturally appropriate and linguistically appropriate care. And with that, I want to start, and hopefully I wasn't sure if the chat's going to be open, but if not, you can put it in the questions in the Q&A. But if the chat is open, you're more than welcome to put in the chat. And I want to invite you to reflect on some of these as we go along through the presentation. Talk about and think about your social location. And if you don't know what social location is, it may have to do with geographical location, but not only geographical, but socially. Understand where we are and where you are in terms of your privileges, oppressions, and intersections. And think about that and reflect on that throughout the presentation. Also, I would invite you to write in the chat how you identify and what is your cultural identity. I would love to see some of that. And how would you define yourself, and how would you define or describe your cultural identity? Maybe with a word or two. And if you don't want to say or explain some of that right now, I just want you, it's okay. And I would love it if you would think about it throughout the presentation and maybe share it further. Caucasian, Southern, thank you. Christian. American. American. So I'm wondering if for some of you, if this is hard or female. Because there are different ways that we can describe our cultural identity. And that's one of the things I want to reflect on, African American, because there's just not the one checkbox that we do when we talk about cultural competency and talking about this. There are many different intersectionalities and identities that we can talk about. Awesome, thank you. Biracial. So how about thinking about this? Have you or anyone you know ever had to seek health care in another country? And did you experience language communication barriers? Think about, if you haven't had to go through this, think about being in another country with the vulnerability of needing healthcare. And what would that look like if they don't understand you, if you can't tell your provider or the provider that's there in an emergency care unit what you need, what you're going through, and what that looked like? I would be terrified to repeat. And there are many reasons for that. Maybe because we don't know, maybe because we don't trust what other countries might be doing or how they're practicing medicine. And I think, and we're going to touch a little bit about trust here in the medical field and what that looks like. Yes, in Canada. So no language barrier. Awesome. But still, I'm sure it felt a little bit strange just being in another country. You're vulnerable. You don't know, I mean, how are you going to pay for this? What is it going to look like? Even if they understand you, we have so many questions, right? Awesome. Thank you for sharing that. What about, do you have patients with a different background than yours? And how does that impact the care you deliver? Let's think about that and let's reflect on that as we go through the webinar and some more conversations on that. Okay. I also wanted to share with you this statement, which I think it's so powerful. It's the idea of isolated societies with shared cultural meanings can lead to dangerous stereotyping, as if entire societies or ethnic groups could be described by simple slogans. Again, that goes with that cultural identity and the intersectionalities that we all have. And when we try to talk about just this whole group thinks this or this whole group thinks that, we are also we're in a dangerous zone there a little bit, because we need to think about individuals and how they identify and what and what part of that shared values and beliefs do they accept or they don't. We need to explore more. And one of the things that I really want you to take away from this webinar is to be curious, to ask more questions. For example, I was born in Puerto Rico and I am the first generation Puerto Rican. So if you ask me, how do I identify as a Puerto Rican. But if you just leave it there, you wouldn't know, you would think that I enjoy Puerto Rican food or have many shared values with the Puerto Rican culture, but not necessarily, because I was raised by Cuban immigrant parents. So the food I eat, most of the values, the way I speak in Spanish is mostly aligned with Cubans and not Puerto Ricans. So again, is that looking more into culture and how that person identifies with their culture. I also want to define, before we start into everything, some key concepts. When we talk about, I'm going to be talking about perinatal here, and that depends on the literature that you read. Perinatal can be defined in many different ways. I'm defining it here and talking about the period from pregnancy up to 1 year after giving birth. So I'm going to be talking about that in general terms. When we talk about cultural competence, and these are different terms that are used a lot when we talk about cultural competence, cultural humility and cultural safety. when we talk about cultural competence, we're talking about a process to achieve levels of awareness, knowledge, and skills along a continuum to increase capacity to work and communicate in cross-cultural situations. So it's a continuum. It's not stagnated. A lot of people, when they think about competence, they think, okay, so I've learned everything I need to know about this, and that's that. I'm done. I took the one webinar, and now I know everything about this one culture or how to work with or take care of persons with a different background. And that's not necessarily like that. The invitation is to always keep learning. And when we talk about cultural humility, it's more of an individual basis, that reflective process of understanding one's biases and privileges, which we all have, managing power imbalances as providers with our patients, and maintaining openness to other cultural identities. And then there's the term cultural safety, which talks about creating that environment that is safe for people. So I think about cultural competence more in an organizational way. What does your organization look like? Do they have cultural competent leaders, for example? How open are they for cultural competence? And then I think about cultural humility more in terms of the individual and what we can do, and how humble we are and open to understanding the person that's in front of us. And then cultural safety has to do more with shared respect, shared meaning, and shared knowledge. So again, that engagement with our patient. Here's a graphic of the continuum of cultural competency that you can look at. I think it's really important to know where we are as an organization, where your organization is, where you are also individually. And it goes from just disruptiveness, cultural disruptiveness, meaning really no openness to changes or differences in cultural groups, to all the way to cultural competence and cultural proficiency. Even. So we can be anywhere along that continuum, and it gives us also kind of a north of where we want to be and where we want to go. In terms of cultural competence and humility as well, they share many factors. When we talk about cultural competence and humility, we want to talk about working with differences, addressing inequalities, working collaboratively, looking at the strengths of the person that we're working with, and bringing our own stories to the situation. So being able to also do that reflective introspection and work that we need to do to understand some of our implicit biases that we've grown up with, that we immediately, as we think of a group, we think that they all eat this kind of food or like this kind of music, and always thinking about of not stereotyping that group, and just thinking about that individual self that we have in front of us. So why is this important, and why do we need to talk about cultural competency within the maternal and pregnancy and perinatal care? Because culture impacts the way we see and experience the world, because it can improve healthcare outcomes and quality of care, because it improves patient satisfaction and their engagement in treatment, because it helps reduce health disparities, and it helps us with effective communication between our patients and ourselves as providers. And most importantly, I think when we talk about cultural competency, it could be a life-saving strategy. And this is so because we know we have a maternal health crisis in the United States, right? We know that Black women are 4 times higher their probability to die during birth than their counterparts. This is why in June 2022, the White House released a blueprint for addressing maternal health crisis, because it's important to reduce those disparities in maternal health outcomes, and we need to start improving the experience of pregnancy, birth, and postpartum for all persons who give birth, right? We also know there are maternity care deserts. And if you haven't seen this report, it was released by March of Dimes, I think last year. And it talks about 35% of US counties do not have a single birthing facility or obstetric clinician. And it actually gives you the distance that people have to travel to get care, especially in rural communities. Also, it talks about maternal mental health dark zones, where we know there are over 150 counties with both high risk populations and large resource gaps. So this is important, and culture is definitely part of why this is happening as well. Part of that crisis looks at maternal health disparities. We know that among Black and Hispanic women, we see here how constantly, this is from 2020, but it has continued, that disparity has continued up to the present, how preterm births are higher with Black and Hispanic and American Indian, American Native populations. Babies born with low birth weights are higher with Black and Hispanic populations. And look at the disparities here with Black women. Pregnancy-related mortality, again, higher for Black people, and infant mortality as well. We also know that there are disparities in treatment and how we perceive treatment. We know that multiracial Hispanic and Black individuals have report higher mistreatment during maternity care than any other race. So again, also looking at this and understanding that we need to train more about cultural competency. We need to, again, look at what we bring into the room and what's happening with the care, especially when there is a disparity, such as this. This was a report from Blue Cross Blue Shield a couple of years ago. And again, it looked at the inequities with mothers who completed the recommended prenatal care, how it's much lower for Black and Hispanics than white women, mothers who felt that their providers spent enough time with them, again, much lower with Black and Hispanic than white women, mothers who felt confident that they received or will receive the care they needed during pregnancy, birth, or postpartum. So again, lower with Black and Hispanics, and mothers who felt they could speak openly about pregnancy with their providers. Again, very lower in Black and Hispanics than white. This has many reasons because one problem does not have one layer, but definitely we can look at the individual situations, but we are more concerned about, and what we can actually work with within this webinar and within ourselves, is the interpersonal layer, where we know there are providers' implicit bias that are causing these disparities and inequities in treatment and care. We want to look at the perceived racial discrimination and the differential obstetric procedures. Eventually, we want to look at the different layers and even look at the public health and legal differences in terms of the lack paid of parental leave and Medicaid and coverage limitations, which all impact the care that the prenatal care that we are providing. So many organizations have already made statements around the importance and the recommendation of cultural competence, including the American Academy of Nursing, ACOG, the American Academy of Pediatrics, the Joint Commission, the World Health Organization. They all agree on the importance of workforce education around cultural competency and the importance of examining and understanding unconscious and implicit bias among healthcare professionals in order to improve the care that we are providing. So understanding all of that and why this is important, then we need to understand how does culture impact perinatal care. And I will be looking at the chat again, because I would love to hear your experiences as providers, with how culture impacts the care. We know that culture has a lot to do with communication. So depending on the person's background, you're going to see how direct we are when we discuss negative or embarrassing information. The extended families involved in pregnancy, that's for sure, especially true in Hispanics and Latinx communities too. How open we are to talking about personal problems, how formal we expect interactions with healthcare providers to be. Culture impacts also the personal warmth and willingness to engage in small talk, and how important that is to some of us when we receive care from a provider, and how we use nonverbal cues, such as eye contact. In some cultures, it's better to be looking down. In other cultures, it's offensive if you're not looking at me straight in the eyes, right? The voice volume, when the voice is so loud, it can be perceived as violent or aggressive, and the facial expressions. This is a great framework for cross-cultural dialogue that I really like. There are many others, but these are called the 4 Rs, and I find it very helpful as it's easy to remember the importance of respecting people for who they are when we are communicating, providing information that is relevant to and respects their worldview, encouraging reciprocity in healthcare relationships and how much we are open to hearing what they need, and enabling individuals to exercise responsibility and agency over their health, right? So one thing that's really important also to talk about is understanding the history, and that lived experiences are shaped by history, and we have a long history of racism in the country. And some of us with marginalized communities also have a history of experimentation with enslaved Black women. We know that the father of gynecology, Dr. Sims, some of the work he did was with enslaved Black women, and how that has created a medical mistrust, right, regarding care and how comfortable we feel going into care. There's also have been in history forced sterilization. For example, in Puerto Rico in the 1930s, women began to get forced sterilization to decrease poverty and the population growth. And in the late 60s, there were forced sterilization of Mexican women that began in California. So that's just some of the examples that we need to be aware of when we talk about why isn't this person coming into treatment? What's happening that I can't really, that rapport is not happening, and how we need to work harder with some populations on establishing trust and engaging in treatment. So this is where I want to hear a little bit about your experiences, maybe in the chat, because culture impacts and could impact the prenatal care that we get and that we receive and how we understand prenatal care. When does it start? When should it start regarding to my culture or my beliefs? Preventive measures. There are some cultures that will not do vaccinations that may be recommended during pregnancy, or will not agree to exams or sonograms, or as many sonograms as we would like to do. And we might need to explain or educate a little bit more. The use of herbs versus medication, being agreeable. You know, there's some that's very common with the Latinos as well. We're very agreeable in the session because we think the doctor is the authority. Again, generalizing, but as a general rule, but then we might not adhere to the recommendations, so again, as a provider, you might be left like, what happened here? They seemed so agreeable and understood everything we were talking about, but then now they're not following the recommendations. And so it's opening it up to conversation and seeing what's happening there. Who comes in? Like somebody was there saying the extended families all involved in the pregnancy, and how open you are as a provider and comfortable with that, and how important that can be for that person. And that support system could be a major difference in the prenatal care and eventually the outcomes. Who provides the care and the gender of that provider could be a factor depending on culture. And we need to consider that as well. Nutrition, what the nutritional needs and what's allowed or not allowed during pregnancy regarding my culture. The accessibility and frequency of prenatal care, including the partners or the elders, might be important in that prenatal care. In other cultures, what's pregnancy and birth and postpartum, it's all about women. And the men really are not included in this process. And that's okay. And just understanding and being aware of those differences. Talking about sexuality could be harder for individuals from some cultures than others. What have been your experiences if in labor and delivery? If are there any labor and delivery nurses here, or doulas, or anyone who participates from labor and delivery? And we can see how many differences there are in different cultures regarding labor and delivery, and regarding the birthing environment and what that can look like. Privacy versus the extended family, how many people we want there, or we don't want anyone. Do we want the father present or not? Language barriers. Are we taking care of that? Do we have interpreters? Are we thinking about that? What about sign language if that's needed? Is that something that we're thinking about when we're treating and providing care? Pain management preferences. There are some cultures that women are supposed to endure that pain, right? And they will decline any type of pain management medication, epidurals, or anything, because they feel like they need to go through that and experience that pain of labor. How about the movement, birthing position, that reverence to the placenta? What are the hospital's policies on that? Can they take the placenta back home to bury or to process, to consume? Is that something that we're open to? Are we talking about that? Are we asking about that? The same with nutritional needs during labor and delivery. What about postpartum care? Very different in different cultures. As a perinatal mental health clinician, one of the things that's really important to me is to screen for mental health, to talk about mental health, because we know that 1 in 5 women may experience perinatal mood and anxiety disorders during this period. And how do we approach that? With the taboos and the stigma regarding mental health with different cultures, how can we better approach that to screen and talk about and educate about mental health? Who takes care of the mother? What are the postpartum care plans? What about when she might be from the same culture that you, but then there's a husband that's from a different culture, a different background, and how is that being considered as well regarding postpartum care? What are some of the protective rituals that are important for both parents, for that family? Again, with nutrition care, with Latinas, we have the cuarentena, which is 40 days after giving birth, where the mom is supposed to be resting. So maybe if she has a postpartum appointment, she won't show up, and it's not because she's resistant to treatment or not adherent, but rather her cultural values and what she's supposed to be doing. In some cultures, you can't wash your hair for that entire month after birth. So again, asking those questions and preparing for that and exploring for that. The same as with family planning. That's going to have an impact depending on the cultural beliefs and values. The same with the newborn care. There are different practices that happen that we should be talking about during pregnancy and in that planning. Circumcision, blood transfusion, or the non-acceptance of blood transfusion, the feeding practices, the importance of names with newborns, the experience of NICU, which could be very traumatic for parents, especially immigrants or parents that are not understanding this care and what's happening and what does NICU mean and why their baby's there and why they can't stay with their baby, if that's a practice in your hospital. Safe sleep practices, that's a big one for different cultures. And especially in cultures where there's multi-generational and there are grandparents saying, this is how we did it and it's okay and you're alive. Why do you need to do this now? Because these safe sleep practices have changed over time. And when there's such importance with the elders and with multi-generational households, it's really hard, and the pregnant person could feel very confused as to who to believe, what to do, what's the best practice. With Latinos, and I always bring this because I think it's important, that where and how do they understand that the illness comes from? And it could be like that evil eye and the need to protect newborns with a stone. So maybe in the NICU, you'll see that they put something around, and just leaving and permitting that and allowing that for parents is important, of what they need to do to protect their children, depending on their culture. And I really wanted to also talk about perinatal loss and the importance of culture when a loss happens, a miscarriage or a loss anytime during pregnancy, birth, or during that first month postpartum. Yesterday, 15th of October, was the World Awareness of Perinatal Loss. It happens in 1 in 4 women. So it's a very common situation that we may encounter as providers with perinatal population. And it's really important, again, to take into consideration what grief looks like within that culture. How do we process grief? What are the beliefs and rituals that need to be done if a baby dies during pregnancy, birth, or postpartum? The importance of spirituality and how we communicate if we don't hear that heartbeat during pregnancy. How do we tell this family and all the cultural barriers that can be in between, to do that sensibly and as much human as possible, and respecting their culture, and such a hard news, right? And when we have immigrant families, that it's you combine a perinatal loss with other losses as well, the loss of not being in your country, not being with your extended family, and now this such a loss as well. So just being conscious and aware of that. I also wanted to talk about the implicit bias and stereotypes, really important. We know the literature is very consistent with this, where they have shown that maternal healthcare providers are significantly less likely to give adequate pain medications to postpartum Black and Hispanic patients. They're less likely to prescribe pain medication to Black and Hispanic women going home after giving birth compared to white women. And they're less likely to ask postpartum women of color about their pain level compared to white women. So again, how implicit bias comes up and the stereotypes that come up during this care. And having said that, I want to move into strategies and what we need to take care of. I really love this quote too. It says providers need patients to educate them about their bodies, concerns, medical history, conditions, desires, and lived experience. In order to do that, patients need providers who listen. Okay. So I think that's very valuable. We need to be able to listen to their stories and understand. And again, looking inward, being aware of our own cultural biases and stereotypes. Accept responsibility to identify and understand your implicit bias. And how do we repair when we overstep? Again, open to hearing some of your experiences. Since we all have cultural biases and stereotypes, sometimes we might assume something. And if that person corrects us, we reset, we apologize, we start again, right? Think about what you bring into the room when you speak to someone else that looks different from you. Are there patients you find it difficult to get along with, relate to, or reach? Do you find that you think about them or talk to them in a certain way? And how do you feel about that? Again, I think these are important questions that we need to reflect on more so than understanding all the different nuances or beliefs and values of the different cultures, which is actually going to be impossible to know every culture that you come across with, but rather think about what comes up with you and how you can do this differently. Thinking back on your recent clinical encounters, how might an implicit bias have influenced your care? And really be honest with yourself here and think about what that looks like and how you can change it or make it differently, or what would you have done differently? When we talk about, again, cultural humility, these are some of the questions we want to ask, and these are some scripts. What would I need to know about you so I can be of help and support? What matters most to you in this experience? Help me understand your explanation of symptoms. That helps a lot when we understand how this person understands their illness, symptoms, or whatever it's happening during their pregnancy care. That'll give us a better understanding on how to solve this. Are there aspects of your background or identity that make a difference to the difficulty you are experiencing? And then ask also, this is very helpful, in your culture, what would you do to resolve this? Again, opening it up to collaboration, to respectfully identifying strategies that can better help your client, and being willing to learn and be open to learn. These are other things we can do that could be helpful when trying to provide culturally competent and linguistically appropriate care. Using stereotype replacement, become aware of the stereotypes you hold and create non-stereotypical alternatives to them. And that's some work that you can do internally. You can remember or imagine someone from a stereotype group who does not fit the stereotype. So maybe someone that you know from the Latin culture that doesn't really fit that stereotype that you have of the Latin culture. Individualizing. I think it's really important to see each person as an individual and not a group member. Perspective taking, and maybe exercising that, putting yourself in the other person's shoes. Contact if you want to know more about the specific culture or this group that you see more of in your clinic or in your private practice, and try to get to know people from different cultures, from that social group. Seek opportunities to engage in discussions in safe environments where you can feel comfortable asking questions and not feel judged. Emotional regulation. Also, reflect on your gut feelings and what comes up when you meet with this person that's different from you. What does that feel like? How does it feel in your body? And what does that mean to you? And maybe have some consultation, some supervision with other colleagues. And use mindfulness technique. I think it's very important to be in the present moment, have your attention in the present moment, so you can recognize those stereotypic thoughts before you can act on them. And I don't know if any of you have used any of these, if you want to share any of that in the chat. But I think these are very helpful strategies that we can use in every day. We want to approach diversity, make space for talking about the past, their home country of the person that you're attending to. If there was an immigration journey, learn about that, ask about that, make time for that, assume a position of curiosity. Use resources for translation when needed. Do not assume phenotype equals genotype or identity. So a person may look a certain way, and that doesn't mean ethnicity or culture or just the one checked box. Again, explore trauma and racial trauma. Be aware of nationality. I think that's very relevant also with us a Latina. Again, thinking about Latinos or Hispanic, we come from different cultures, different nations. We wave different flags and could have very different shared values, beliefs within our culture. So I think that's also important. So don't think you're a Latina or Hispanic and that's it, but where specifically are you from? What does that look like? And ask questions about it and be willing to acknowledge also your racial and ethnic identity and what that means and brings into the relationship of care. I think it's also very important to talk about health literacy and do not make assumptions about a patient's health literacy skills. No, okay, thank you for that. Knowing when translation service is not sufficient, that there is a language and cultural barrier, and getting the client to a colleague that is more competent to meet their needs. Also, that's great. So yes, so knowing when translation services, not only, we might not have translation services available, and maybe referring to a colleague that is better suited to serve this client might be what the competent way to meet these needs. Thank you for sharing that. In terms of health literacy, also, I think it's very important to use plain non-medical language when we talk to our patients. Use the patient's words to repeat back how they're understanding this and how you can better explain what's happening. Slowing down and speaking clearly and at a moderate pace. Limit and repeat messages. Be specific and concrete. Show graphics when you can. I mean, pictures may speak louder than words, and all pictures and models should be simple as well. Demonstrate how it's done. So for me as a therapist, one of the things that I do is I recommend deep breathing. A lot of the times I don't assume that people know how to breathe or that how they can do deep breathing, especially during pregnancy. So we do it together before they leave my office, and we practice together. And I ask, how would you do this? And then I show how I would do it, and then we do it together. So demonstrating how it's done could be very powerful as well. Cultural understanding. We want to ask some of these questions. What does motherhood look like within your family's expectations? What role does religion play during this period of your life? How do you understand maternal health care? I want to make sure that I understand your perspective. What are your main goals for labor and delivery? What are your biggest fears? How can I best support you? Again, this could mean so many things. This could mean we need to refer out, maybe. So again, asking what this person needs, how do they understand this process, and what are their preferences? What plans have you made about this pregnancy? what role do early experiences, migration history, family dynamics, cultural patterns of expressing distress, any of these play in the presenting symptoms, either exacerbating or the stressors and reactions? What are some of the protective factors as well? So when we talk about culturally responsive care, we want to be aware of our own cultural background and biases. We want to have the most knowledge that we can of our client's worldview, and we want to again, develop these skills in implementing clinical strategies that are appropriate to a client, always remembering that a person is the expert in his, her own lived experiences. So we've talked about things we can do, but also what we can do with our space. In our space, our posters with signs, symptoms, and resources actually are welcoming to the people that we are taking care of or that we are serving. Is there literature in Spanish or other languages that is relevant to the person that is receiving the care? Are there people that look like me and talk like me that I can refer to? What does that look like? Because sometimes there is, sometimes there isn't. And when there isn't, then we need to do our best to provide a culturally competent and relevant service. So is the space welcoming to parents? Can they come in with their strollers? Do they fit through the door? Do we have changing tables? What does that look like? Transportation, is it accessible? Are we having environments that are private and provide dignified care? So these are all things that we should be thinking about. I started off talking about the differences in cultural identity and the importance of intersectionality. I want to bring that back and just reflect on this and get your thoughts about this a little bit. So let's say Crystal is a new patient of yours. You can think about her identity as a Black woman and how that shapes her life experiences. However, again, race and gender are just two social identities. Crystal could identify primarily as Black, heterosexual, low-income women who immigrated to the US 10 years ago, or a Black, lesbian, affluent woman who grew up in poverty, or a Black Christian suburban woman who has a physical disability. So again, if we only think about race and gender and forget the unique life experiences of that person that is in front of us, we are missing the point and we're truly not providing culturally appropriate care. We need to ask and look at the bigger picture and the different intersectionalities and identities that we all have. And before I open it up to questions and a little bit more of conversation and hopefully some of your feedback and reflection in this, I want to summarize what we talked about a little bit about the importance of cultural care in maternity. Healthcare is critical for ensuring quality patient care. The importance of learning about our own and other cultural identities. The practice of self-reflection, which I think is key to offering culturally competent and linguistically appropriate care. How we need to combat bias and stereotypes, and always being aware of that and calling ourselves into that and understanding when we are thinking about that and what that looks like. Be open to learning and growing from people whose beliefs, values, and worldviews are different from ours. And never assume, and use what you know about that cultural group to ask questions about individual experiences. And if and when we assume, again, be accountable and start over. And just say, I'm sorry, I assumed this, pardon me, let's start over. That's not my intention. Okay. So here's some resources if you want to look for more information about how culture and culturally competent care is important in maternal and infant care, and some of the disparities. These are wonderful resources on cultural competency, cultural humility, the impact of racism, and the impact that racism has on physical health and what's called weathering, and how we get sick more when we experience that racism, and that how that has to do also with cultural care and just cultural competency and the importance of keeping all of that in mind. I also want to share with you that PSI, Postpartum Support International, has support groups for pregnant and postpartum individuals. And it has so many diverse groups. It has groups for Black mamas, for Desi mamas, for Hispanic mamas, for queer trans birthing individuals. So please look it up and have it as a resource if you do need it. And I'll open it for questions if there are any. And I want to thank you for your participation in the chat.
All right, thank you, Dr. Rodriguez, for the insightful presentation. So yes, if anyone has any questions, they can either put them in the webinar chat or in the Q&A, and one of us will ask it.
Questions, reflections, any comments?
We've got a few comments in the chat. Great overview and very informative. Great presentation. Someone else also said thank you.
Oh, thank you for having this time with me this afternoon. I hopefully glad you enjoyed the presentation. Hopefully I left you with some reflections and some things that you can go back to in your group and where you work at and discuss a little bit further. I think again, this is an ongoing process. It's not like I took this and now I'm done and I have all the information I need to know to be culturally competent. I think it's a little bit of just opening it up to more conversations that we need to have and keep having. Here's some references and here's my contact information. Yes, the thought about the culture of a family for foster care, children and adoptees. You want to tell me a little bit more about that, Ilana? Hopefully I'm saying your name right. Well, I don't know. Yes. Reminded me of foster children and adoptees who are placed with families of death. Correct. Yes. Again, how we define culture and what culture is. And again, I would like to remind everyone that there is no default culture. There's not the right culture and then everyone else, but how we within our cultures and within even our families, we have different ways. I mean, right, what breakfast looks like in where I come from, and what breakfast looks like in the family, maybe of my foster care family. And I remember, it just makes me think about this social worker who told me about, she was all worried because the kids were saying that they weren't getting fed breakfast, and they were getting served scrambled eggs or pancakes, but they were used to rice and beans for breakfast. So they thought, I'm not getting breakfast. So there are differences within our own culture, within our own family backgrounds that always, this is why this is an ongoing process, that we can't just stop and now think that I'm competent and I know everything about this one culture or this one group, because it's constantly changing, and it's different with what we bring and the different intersectionality. So yes, thank you for sharing that. Infant and early childhood mental health, but I appreciate extending this conversation. Yes. Great. Thank you, Beth. Well, I hope you all have a wonderful afternoon. I thank you, and thanks to everyone who was here.
Yes. So go ahead and close. Thank you again to Dr. Rodriguez for her time and expertise, and to all of you for joining today's important conversation. As we continue to strive for cultural competency in all aspects of our work, it is vital to keep these conversations going. I encourage you all to take these learnings back to your organizations and communities. Once we confirm attendance, you'll be emailed a link to complete the evaluation. Please complete the evaluation by the close of business on October 23rd. Once you complete the evaluation, please allow 2 weeks to receive your certificate or contact verification form. Thank you again, and we hope to see you at our next Cultural Competency Unlocked webinar on November 20th with a focus on veterans. If you haven't already, please visit vitalalabama.com to register, and have a great day.
Thank you.
Yes, thank you.